So welcome to another episode of our Spotlight series. Very excited today to have our first fully fledged qualified doctor. So we get to find out about her path to medicine, and then actually we have quite a lot to explore in her journey as a doctor. So welcoming on Lauren here. Hi, thank you so much for your time today.
Hi, hello everyone.
Yeah. So if we start, I suppose, back at the beginning, around kind of from schoolish time, or from when you feel like your journey to medicine started, if you can tell us about that, that'd be perfect. Thank you.
So I have had the weirdest route into medicine, ever.
Yeah.
I might be the only sort of British-born doctor in the country that doesn't have any A-levels. So okay. I was sort of a mediocre student at school, really unfocused. Not because I was a bad kid or anything like that, just because I don't feel that I had the social structure for anyone to sort of sit down with me and say, you really need to think about what you want to do. So I just sort of, floated through, not a terrible student, not a great student, just, an average kid. And I went to college, dropped out, hated it, sort of went back, hated it, dropped out again. And I got a job working in B&M bargains, and I just found it so mind-numbingly boring. Like from there, I went on and I worked in banks. I worked in 2 banks, and I found that so monotonous. And I kind of I felt like I was staring down the barrel at 35 years worth of, counting money, and it just felt completely untenable. And I just remember such a feeling of sort of despair, and life shouldn't be like that. You should be excited. What am I going to do with the rest, the rest of my life? And I didn't feel like that. So I had a bit of a think, and I thought, do you know what? Teaching is probably, it didn't light any fires in me, but I thought, do you know what? Maybe I could go be a teacher. It's got to be better than this, bank thing. So I went and did an access course, and full-time. So for those of you that don't know, it's a bit like being at college except a lower level. So it's full-time, and I did geology, biology, history, RE, those kind of, no, not RE, I did philosophy, I think. And just having had that break from school, and then going back into education, just did something. I needed the break because I hadn't appreciated it when I was at school. And once I got back, I realized how rejuvenating studying is for me. So studying is something that is completely central to my well-being. You don't really realize that when you're at school, because you don't get a break from it. It's forced upon you. It's not something you choose. So you come out, you do a couple of jobs that you hate, and then you realize how much of a privilege education is. So I got the education bug, and I was like, right, well, I don't really want to be a teacher. So what do I want to do? So I was doing really well at philosophy. I got an A-star at GCSE and RE. I thought, do you know what? I'm going to go and do theology. So I wrote, obviously, so it's quite difficult to get into theology when you don't to a good university without any A-levels, but they very kindly let me in after some gentle persuasion and some essay writing and interviews and things like that. So I'm now on a theology degree, and I have a great first year because I'm not thinking about the eternity of the rest of my life. But once I get to second year, I'm starting to think what we're going to do. And I'd done some volunteering with the Red Cross. A couple of people had sort of collapsed at my workplace, once when I was at the bank, and once when I was working as a waitress. And there was an occasion where an old chap had come in with his sister and his wife. They'd come for a carvery. He'd gone to fetch the car, and he'd sat down to bring the car down, so the sister was in the wheelchair, and he just passed away. And I'd just started my first aider course. I wasn't even a fully qualified first aider, and the actual first aider was gone. So it had to be me. I ran up there, and we got him out of the car. I did CPR, and then the 2 paramedics came, and this guy he was 87, 90 of the day, and the paramedics came, and they worked on this chap for so long. They pulled out all the stops to resuscitate this guy as if he was 18 or 87. And there was something so humbling about that. like such a, it just was such a wonderful thing to see how much effort they went to for this chap. And sadly he passed away, but that kind of lit the medicine bug in me. And then I kind of thought to myself, maybe I could do psychiatry, because having not been from a science background, there's no way when I was, first considering doing medicine that I found medicine approachable. And I don't know if that's what people watch in this field, but I think sometimes if you're not from a traditional non-science background, the idea of being a doctor is completely intimidating. You think that all medics are from like really strong biology, they have those little like plastic skeleton. I mean, I had one of those little plastic things when you were kids, or went to school dressed as a doctor at the age of 6. And actually it wasn't like that for me. I barely did science at GCSE, so my entry was kind of like thinking I'd do psychiatry, and the rest is history. And at some point, I love the pathology of psychiatry. It's fascinating, but psychiatry is not for me. All respect to them, but it's not for me. And at some point, I decided to do probably one of the most sciencey things, which is surgery. So now I'm training to be a surgeon. So how I've gone from, being an A-level dropout, who was absolutely miserable, like kicking her heels, trying to get up every day to do this bank job, and now, it sounds simplistic, there's been a lot of heartache and struggles, down these years, but here we are.
Yeah, thank you. It's one of those moments, I can imagine it, those life-changing moments, you describe it in such detail, and imagine it's something that stays with you forever, that experience of the paramedics and being with that gentleman. I bet not many people get such a moment in their life to show them the possibilities, or show them what they could be interested in. Just interesting to hear you talk about it as if it just happened the other day.
That's a long time ago, that one. Very long time ago.
Really like pivotal moment. So when you're talking about going to study medicine, and you have this unusual background, how did that affect what med schools you could apply to, and how did it affect that process?
So it is much more difficult, because I can only apply to a subset of universities that take non-science backgrounds, and there's only a few of them. I think Exeter is one, Nottingham is definitely one, because that's where I went. So there are a few of them. There's about 5, I think. I have a 2-1, luckily, but these universities do say that. So it's like the higher your GAMSAT score is, the higher your degree is, the lower your GAMSAT can be. So it can be quite difficult if you're coming from a non-science background and you're at a 2-2, but it's definitely doable. So I think it was difficult, especially because I had a little boy. My son was 15 months old when I went to medical school. So I think mentally it was difficult, because a lot of people just thought, when I said that I was going to go and be a doctor, they forget now, because it's like, second nature, but everyone just thought it was a phase, it wasn't going to happen. I had my son, and I was studying all the time for the GAMSAT, and everyone just thought, was sort of thinking, when is this going to blow over? And so it is more difficult. It limits where you can apply to. And in addition to that, if like me, the thing with mature medics and graduate medics is you're often not free as a bird. You're often tied to a place. Either you've got to work, you've got a mortgage, or in my case, you've got a child. So I couldn't apply to all of those universities. It was Nottingham or nothing. So I did get in eventually, but it did take a few tries.
Perfect. And was that for their undergrad course or their grad course?
Grad course.
Yeah, grad course. Because I think, there's obviously maybe more choice with undergrad, but there's the financial implications, and they still ask for particular GCSEs and A-levels sometimes as well. So can open up possibilities, but still doesn't make it, a huge range. So in Nottingham, so that's where kind of you're based, and you were able to stay there. How did you find the transition from theology to medicine?
Oh, so difficult, because theology is an arts degree. It's about reading and interpreting and creating an argument, writing an essay. Medicine is recall, it's memorization, it's all of these body systems that I never really learned the first time around. So I had a really difficult first few years of medicine. I would say, so because graduate entry is split into two portions, the bit that you do it accelerated, because obviously it's 4 years, not 5, and that's the preclinical bit that you do a year faster than the undergraduates. So that's a lot of work. So if you think about your typical undergrad, they've usually got A's in biology and all of those kind of science subjects, and they are going to tell you how difficult their preclinical years are. You are going to do it a year quicker than that. So the level of work, I mean, it's hard. It's really hard. I had my son as well. It was completely manageable. So what I would do is I would try and leave about 4:30, 4:45-ish at the latest, pick him up from nursery, because I was a single mom as well. So it was tough. I would get home, play with him, give him dinner, put him to bed, and then I would usually work until bedtime. But I would not work at weekends, because that was my time with him. Sometimes he'd be with his dad on the alternate weekend, and I'd work then. But yeah, so it was very, very difficult, because there aren't that many sort of like, a lot of people who do graduate entry medicine will have come from a biomedical sciences background. So they've already done a lot of that content. If you're from a non-science background, you are literally walking in with nothing and having to start, on day one at the cell, and you're like, oh, mitochondria. So I kind of remember that, and it's all fresh and new. Once you get through that first year and a half, if you can survive that, I think personally, I don't know if you agree, now that you're clinical, rest is easier, because you're just repeating and laying down on those foundations. It's still harder because everyone else is already laying down foundations on foundations, but you've already covered everything once. So actually, once you get to your clinical years, I think it's easier. And I came from a non-science background. I was a single mom, and I didn't do badly. I graduated in the 3rd centile. So I didn't graduate right at the top of my class, but also I was, in terms of the stratified level of how it is, I didn't do too badly at all. So those of us who are graduate medics, we can do well. It's not just about just scraping a pass and lumbering through and going into GP. You can go and do whatever you want to do.
And I don't know, I definitely agree with you do just build and build on the knowledge. Whether you found that once you got into clinical years, just by the fact that you've been around a bit longer, you've done a degree, you're more comfortable with people, that actually in that environment, you potentially, also everyone's different. People come in at 18 sometimes and are really confident in it, but actually you can bring in some other skills.
Oh, absolutely. Consultants used to say to me all the time, you can always tell, they used to say a NOTS grad, but that's obviously because in the hospitals that that's where they're populating from. But yeah, you would find that graduates are more confident. I think you're better with people. You've got better communication skills, just because most of us have had other degrees or jobs, and like you said, it's talking to people, building a rapport. So I think grads often find that stuff a little bit easier.
And talking about your love of studying, would you say that kind of helped you in the beginning take to this new material, and like you said, all that rote learning and recall? Were there any particular study strategies that you really love? Or
so, well, yeah, I mean, I just love studying. I just love it. It's just one of the joys of life. Like, I want to continually rediscover things. And I think in terms of study tips, it's really, really important to get an understanding of how you best learn. So, for me, I would say to everyone, if you don't know what the Pomodoro method is, go away and look at that, because that, your brain does fry after so long. But there's so many resources out there now which are really helpful. So if you're someone that's studying for the GAMSAT or newly at medical school, things like Khan Academy or Armando Hasudigan, handwritten tutorials, those things on YouTube are really, really helpful. And I would kind of like combine that with anatomy colouring books and Anki flashcards and anatomy flashcards. And I think we had these big whiteboards, and I would use those. And working with friends as well to try and get the recall. And I think the most important thing for everyone is just to understand how you learn best, because it's different for all of us, and you'll save yourself a lot of time if you can work out how it goes into your head.
And thinking about like over the years and different study material up until now, because obviously there's still exams as you go forward, has your study method changed? Because I found from my undergrad to medicine, actually the first year I stuck my heels in a bit and I was like, oh, I'm going to study the same as I did before. But actually, you know, spaced repetition became a huge thing, and I had to really adapt. So did you find, you know, something similar through your years of study?
Yeah, definitely. And it's always evolving, because a lot of the skills are different. So medicine is a really difficult degree, because you're not just being expected to learn one thing. So you need to have great communication skills. That requires one way of learning. You need to have great clinical skills. You need to understand how to kind of palpate the body and look for physical findings. That's not something that you can rote learn. And then you need to be able to, you know, sort of understand anatomy. And then a lot of medicine, unfortunately, is rote learning lists and things like that. I think the key that I've learned as I've come through is that it's worth making the effort to try and understand the process rather than rote learning so much. But sometimes you just have to rote learn. And I think, yeah, it has changed and it has evolved. When I was doing GEM, I was like Anki crazy. I was doing everything on Anki for finals. But actually, when I started revising for MRCS, I dug my heels in too. I was like, this works for me, Anki cards all the way. And actually, for whatever reason, I don't know why, it just does not work for MRCS. And I think that's because it's very anatomy based. And I'm very visual. I need to visualize the anatomy in 3D. So yeah, I think you have to be really self-reflective of your own process and think, you know, if your grades aren't great, it's not you, it's your study process, and be kind to yourself, and just to think, you know, something's wrong here, and to go and ask your colleagues, like, how are you studying for this? I think that's really helpful.
And I think it's really good that you've talked about that it's busy and it's a lot, but it's manageable. You know, you've got light outside. Yeah. How does the GEM compare to kind of your schedule like now?
Yeah, do you know what people always say to you in medical school? Like you say something like, oh, it's so hard, I'm really struggling, and Grinch appears from somewhere and they're like, just wait till you're an actor. It's not true. It's not true. I think, and this is a hill I will die on, being a med student is harder than being a doctor. And that's because they're always throwing around phrases like, you'll get terminated if you don't like pass this year, you have to resit a year or whatever. So I failed an exam a couple of weeks ago. It cost me £600. So I've got to fork out £600 and study again for another X amount of months. But no one's failing me. You know, I haven't failed the year. I just need to revisit it. And I get paid, which makes a massive difference. And your life is just a little bit more in your control when you're a doctor. So it's just so much easier. It's so different. It's just so different.
So really reassuring to hear, because like you said, a lot of people say, you know, you've got it easy now, and you know, you wait.
So in terms of my study, so when I first started GEM and I was preclinical, I was working, must be, because obviously, and GEM is full-time, but then your study is on top of that. So, you know, you would have a full day of lectures, clinical stuff, anatomy workshop, but then you go home and you study and prep the lectures. So I was probably doing about 60 hours a week in those first 18 months, just because I struggled so much coming from a non-clinical background. When I was an F1, I did an average of 50 hours a week, full time. Only in 2 years, I only had a period of about 3 weeks where I was like soul destroyingly, I think I had a run of about 72 hours once, which was horrendous, and it was like in RAU over the winter, and I was just like, I would have even gone back to med school at that point. But now I'm less than full time, so I've worked 2 days this week. I'm doing 5 next, so I do tend to do an average of about 40 to 55 hours a week usually. It's supposed to be 32, but for some reason it seems like more. But I'm doing a lot less hours than I was doing med school, because in med school it's not flexible. You've got no control over anything, and that I think even if you're not consciously thinking about that, that pressure is on you. Whereas when you get to foundation, and when you get beyond, because I'm a core surgical trainee now, it's a bit more in your control. So you can take a step back and say, look, this is too many hours. I'm dropping down to 80% or 70 or 60 or 50.
And I suppose at the moment as well, one of the positives of medical student is the responsibility is not on us at all. It's purely for learning, which is a huge privilege to be in. But hopefully once you qualify, that responsibility isn't so daunting, perhaps.
Yeah, I mean, so it's the thing I think that everyone struggles with, is that rite of passage is, the training wheels come off and you're responsible for your patients. But in hours, there's always going to be someone around, because there's, registrars and consultants and things like that. And out of hours, we definitely feel a bit at sea. And it took me a surprisingly long time just to realize that all that's expected of you out of hours, if someone's acutely unwell, is to do what you've been taught at med school, which is to do your A to E and escalate, A to E, stabilize and escalate. And that's all anyone's expecting you to do. And then there should be someone more senior who can come and, have a look. So in terms of responsibility, I think we feel like we've got a lot of responsibility, because obviously we do. And it's always in your, it's always your choice as to whether you're going to go review the patient or whether you're going to tick all the boxes and do the ABGs and all of the things that you should do. But actually, now that I look back a little bit, perhaps now that I'm a little bit more senior, perhaps I'm wearing, rosy coloured glasses here, but yeah, I think it's all right. It's okay.
Okay. Very reassuring.
I love being a doctor.
Yeah.
You're gonna love it. The first couple of months will be awful. You'll cry in a toilet. It's a rite of passage, but it's fine.
Perfect. So kind of back to your journey. So you had 4 years on the GEM course. Were you thinking about surgery then already, or how did your kind of foundation years start?
No, I was, so I was really on the fence. I really like medicine. Medicine is more my forte. So obviously I'm not from a science background. I'm really good at diagnosis, and I'm really rubbish at anatomy. It's just, I really struggle with that visual kind of stuff. So I had kind of thought about doing obs and gynae, actually, because it's that nice mix of a bit of surgery, medicine, love working with women, love babies. And then I got to foundation and I did cardiothoracics as an F1. And I just loved it. I really loved it. So a lot of surgeons will say they wanted to be a surgeon since, the onset of the dawn of time. But actually, it's very difficult to know what you want to do until you've been in F1 and have worked it, because everyone always says, they don't mind the on-calls and they don't mind the hours and the nights. And then when you actually work them, you get to experience what that life is like, and it isn't for everyone. I personally hate night shifts. I've got some in a few weeks, but yeah, I love it. So I didn't know actually until post qualification.
And yeah, the anatomy, I was going to say, for non-science background, anatomy is a huge.
I'm so bad at it. It's just have to keep, I study all the time. Like I listen to a podcast on the way home from work, and like every second of the day is studying, because that's what it takes to get it into my brain, unfortunately. But
and when you are having practical experience, when you're in theatre, how much training do you feel, or do you get teaching moments within that to try and reinforce it?
Yeah, so as a core surgical trainee, that's basically my whole job in hours, is I go and do the ward round in the morning, and then I can kind of just go wherever in theatre, wherever will have me. And I would be expected to do things like opening and closing, nothing more complicated than that. And that would be well supervised by usually a registrar and a consultant. So that's very much built into my job role now that I'm a core surgical trainee. In terms of being a med student and being a foundation trainee, it isn't so much written into your job plan, but consultants and registrars are always happy to have enthusiastic and eager med students and foundation doctors. So if anyone does want to, whatever level you're at, if you want to go and get some experience, just go and chat to your consultant and say, I'd really like to, you know, watch you suture perhaps, and they'll supervise you, give you some stuff to practice with at home as well.
Yeah, we did a suturing workshop on the foam pads, and I think even then you start to see that some people were saying, oh, this is so relaxing, you know, and made me almost angry, you know, you're frustrated and you're like, this is like fiddly, stupid suturing. And I think, yeah, not for me. I think apart from the anatomy, I can't imagine ever, you know, finding the love for it. You know, you talk about studying, and I think, don't know if you find it's just studying in general, or you have to have that fire in like, this is interesting, I love to learn this.
Yeah.
And I think, anatomy I struggle with.
It's hard, it's just so much.
Yeah, it's so much, and I think, like you said, it's very visual. And I think for me, I quite like this makes, you know, I understand this, which leads to this, and more a story. Whereas I find anatomy quite, this is this, you know, and it connects to this. And I suppose you can get the picture of the flow in the body, I suppose. But yeah, I think something quite radical would have to happen for me to think surgery could be for me. But still time. There's still time. So do you mind talking a bit more about, so on your foundation years, what other rotations you did?
So I did cardiothoracic surgery, hematology, and then I did child psychiatry. So I had a very niche foundation program, which isn't ideal actually, because it meant that I didn't get great general surgical experience. And then in F2 I did obs and gynae, community gerries, which is based in ED, and basically you just review any geriatric patients coming in through ED and see if you can send them home, because often people get brought in for social reasons, or you put an old person with good function in a bed for 3 weeks and they're never going back into their own home again, they're getting into a nursing home. So it's really important to kind of bounce them out if they're well enough to go. So that's what I used to do there. And then that took us to, I was on that rotation in December to March, or the start of April of 2020. And then COVID hit. And that was a very bizarre experience, because they started, that's when, in that March of 2020, they started to really change ED, and they took over our offices and things like that. So I should have gone on to ENT after that. But at that point, I was about 36 weeks pregnant anyway. So they pensioned me off a bit early because I was pregnant. And then I came back 8 months later, and I did a little bit of GP, 8 weeks at 60%. And I did trauma and orthopedics for a couple of months to finish off too. So I've done, looking back on it now, they're all just such different, very niche jobs, but yeah, all good fun.
Yeah, that's quite, I suppose, when you're in education, you always think of everything having to move in academic years. And I, you know, like you were saying about kind of the fear of failing was that you'd have to resit a whole year. But the idea, you know, if you took a break to, you know, to have a baby, that you could pause mid-year and come back and finish it. I think it's just again a nice thing to hear out loud, that once you move away from being a student, not everything has to be completed in year-long blocks.
Well, you know, if you need to take the time, you take the time. I took a year out in med school. I had a really bad run of like things that were going on in my life which were awful and traumatic, and I got through them, and I lumbered on for like a year and a half, I still 2 years, and then I just everything started going like, and I knew that I had to take a step back. So you can do that in med school, and again, it is still difficult as a doctor, because obviously things still go in blocks. So there's obviously like this foundation, and then there's your core training or IMT, etc., and that's your run through, and then there's your reg. So there are kind of defined blocks, but yeah, you know, they understand a bit more that life happens. And if you need to take time out, they'll extend your training. But as long as you don't mind that, you know, life's to be lived, you know?
Yeah, I've been pondering the question of intercalation, but yeah, I think probably we're gonna move through and try and get finished. But there's just so many interesting things, you know, to be done. And I think medicine brings up so many opportunities for, you know, outreach work, you know, community work, other projects. I'm not sure if you found something similar.
Yeah, I mean, one of the things I love about medicine is that there are so many different personality types. That's because there's so many different things that you can do with it. You know, you can be someone who's really interested in the minutiae of like histology or cell types, and you know, you can spend an entire career just looking at that and never get to the bottom of it. Or you know, you can be someone who's interested in public health and you know, never go near a lab, or even a patient. You know, your work is here in a computer, or you know, you can be someone who spends all day wearing a clown nose, you know, in PZD. And I love that. You're right. So there's just so much to be discovered, whatever kind of person you are, and you can go off down these little nooks and crannies, and I love that about medicine.
Because alongside medicine, you do a lot of social media content, so you have your Instagram page and you have your YouTube. What got you into doing those?
Well, at the start I kind of told you about, you know, my background is quite odd. I'm from a working class background. I did badly at school. I had a child. I was a single mother before, you know, I walked through the doors of GEM on the first day. And a lot of people were just, you know, kind of saying to me how inspiring it was to see someone like them go and do this, and it showed them that actually that they could go and do this. So I just started off just answering questions for people. And then, you know, I didn't really start doing social media properly until about a year, less than a year ago, really. I've been doing it for a while, but not at the same kind of degree that I do now. And when I decided that I wanted to do surgery sort of proper, it became a women in surgery thing and a mothers in surgery thing. And I just wanted to show people the reality of it, really. It's not even a, you know, here I am, I can do it. It's you know, this is the cost of doing it, and these are the benefits of doing it. So it's not always easy. I mean, I've never missed a nativity play. I've been at every parents' evening, so you know, I'm around. But I just thought it would be really cool and interesting for people to see someone non-traditional like me moving through the process as a young surgeon. So that's why I do it.
Yeah, absolutely. And I think it's a similar idea to the general, you know, whole Mature Medics platform. It's just highlighting that different people can enter medicine, because it does seem fairly homogenous.
Yeah, and older people and less homogenous people bring something so diverse to medicine. So I was saying about how, you know, there's all these different bits of medicine, and we need different people to go into all of those bits of medicine.
I think it helps understand patients better as well, because you bring in people with different experiences, different family, different social experiences that can actually kind of, I suppose, change maybe a echo chamber of what people believe, you know, patients experience and that sort of thing. So I do think it's really important that medicine opens up more.
Yeah, absolutely. I did a video recently with Phoebe, and she was talking about something very similar. And she was talking about someone who she knows who's had a lot of bad experiences with doctors, and that's because that person associates and is uncomfortable with people who are, you know, fit into the stereotype of male, white, 50-plus-year-old doctors. And, you know, having different doctors in different people can be really helpful.
I think especially when the first kind of, it's very academic, you have to study, you have to have, you know, all the academic knowledge, but at the end of the day, someone has to trust you, and they have to want to listen to you for that knowledge to have any worth in passing over.
Yeah, I mean, absolutely. And you know, we said earlier about how important it is, you know, to have rapport, and how much better we seem to be at creating rapport because we've been around a little bit and we're a bit more confident. But actually, rapport is the thing that allows you build trust. And without that, you're just not able to work as a doctor. There's been so many times where I've seen patients, like for instance, when I was in GP, I saw a chap who he'd ended up having his leg amputated at the knee because he'd had either a melanoma or a squamous cell carcinoma that had gone manky and it spread, and they'd ended up taking the leg off. And he came in just about the stump rubbing, and you know, it's all he was talking about. We got to chatting, we built up a little bit of rapport, and in the end he confided to me and got really upset and broke down, and you know, he was saying how hard it had been for him to voice this, but he was terrified that one of the lumps that developed on his stump was a recurrence of the cancer. And it was really difficult for him to be able to voice that. And the only reason he thought it was like the doorknob question. It was the thing that he brought up as he was leaving, because he didn't want to seem silly. But because I was able to establish a really good rapport with him, he was able to, you know, I was able to kind of, you know, say, you know, I got the qualified GP, and the GP took one look at it and was like, it's a callus. It's absolutely fine. It's nothing to worry about. And you could just see like the colour going back to this chap's face. But we leave our patients in an existential angst if we're not a person who's offering them and giving them some trust, and you know, they put our trust in us. And yeah, so older people from different cultures as well. So language is a really important thing. So I've seen patients in hospital or I've heard from colleagues who speak different languages, of patients who have had a really rough time because people aren't using translators, which is my biggest like gripe. I absolutely hate it, but who speak a language and go and speak to a patient in their language, and all this stuff comes out that the patient hasn't been confiding because no one speaks their language. So we need people from different backgrounds.
Yeah, absolutely. And surgery particularly has a bit of a reputation for potentially being very male dominated, maybe not as family friendly. Is that something you've experienced?
This is a question that I battle with, because I don't know whether, so I feel sometimes very self-conscious. So when I'm not as good at something as some of the other full-time non-parent core trainees, I feel very unhappy about that. But I don't know whether that's because there is a genuine male dominance, a non-female, non-child kind of thing going on in surgery, or because I perceive that there is, and therefore I pull that back onto my own anxieties being projected rather than anyone else's. So I would have to say I haven't experienced really any overt problems. All of the consultants that I work with, especially the male ones, are amazing. They're very supportive. Everyone knows that I'm less than full time. So we're filming, I don't know when people will see this, we're filming this in November. I've only been a core trainee since August. I think since then I've had to have 3 days off sick with my baby. So I've had to have those conversations, and actually it's been fine. So I don't think that it is particularly bad. I did go to a anatomy cadaveric session, which was run by some old retired surgeons who were wonderful and were lovely and very kind, but one of them didn't really look at me. He looked at the 4 male CTs and had conversations with them rather than me. And the other one was very sweet, but kept calling me love and sweetheart and things like that, where he didn't do that with the boys. But other than that, I have to say, I mean, it's fine. Like there's a lot of women, a lot of female registrars. And where I work, the TPD is a female, and one of our female consultants is just been made a professor, and they're both amazing women, and I think they put the boys in order, to be honest. So you know, these women are coming through. Yeah, I think it's fine. I don't think it's anything to put anyone off.
Yeah, that's great. And I think sometimes it maybe comes from, if you are, say, the only person that's less than full time, it feels maybe like it's a bigger deal. Whereas if more people were doing it, perhaps if men were encouraged to go less than full time, if it was, you know, there was just more people having a bigger variety of lifestyles and how medicine fitted in with that, it wouldn't be so unusual that someone did that.
Yeah, so the thing with less than full time at the moment is certain specialities will let you go less than full time for any reason. Most specialities only let you go less than full time for specific reasons, surgery of which being in the latter category. So we're talking about things like caring for a relative, some form of ill health, disability, or something like that, or childcare. I think they're the main sort of reasons. Specialities, some specialities, and the ones that are most female focused have moved away from this. So pediatrics isn't like this, I don't think. Obs and gynae, I don't think, and GP is not either. So hopefully we are moving to a place where anyone can go less than full time, because I don't know about you, but I would rather have one of my relatives cared for by a junior doctor that's not burned out. So I would, if your doctor is a, let's say, 25-year-old person who's come straight through, you know, he doesn't have any of the factors that might make a person think that he's at risk of burning out. He's not caring for anyone. He's not got children. He's not got, you know, second mortgage to worry about. But he feels like working 100% is just too much for him. And he wants to go down to 80% because he wants to be able to go to the gym on a Friday and write his research papers or whatever. I think he should be allowed to do that because I think that makes him a safer doctor and a happier doctor. And I think that he will have less time off sick and all of those things. That is the way it is in GP at the moment, because GPs book by sessions. So that's either a morning or an afternoon. No one does 10 sessions in GP anymore. But it's not quite the way we're at in surgery as yet. I certainly feel like I'm living an amazing life at the moment, because I come up with baby. I feel like I go to work when I want to at the moment. I'm just about to go back on call, so I won't be saying this in a few weeks. But yeah, there is balance to be had.
I think actually also tying into all the opportunities that open up with medicine, you know, like you said, research, volunteering work,
teaching,
allowing people time to invest their skills and their experience in those sorts of projects, that will then filter back in their work as a doctor, in both being a bit refreshed, but also the skills that will bring in. So I just think you could have such a richer work environment, allowing people to explore those avenues and then also not be burnt out from it.
People who want to be at work, right? Not someone who's dragging themselves there.
Just need a bit more funding, more doctors, less strain on patients, you know, just those small factors to sort out before it might happen.
Yeah, well, hopefully we'll be all right at some, well, no, we're never going to be all right, are we, from numbers, but
yeah, like you said, it would probably end up, it would keep potentially more people in the profession, less people off sick.
That's exactly what will happen. Yeah, so stop. Well, you know, we've got, you know, people emigrate and burn out, take years out. They're working in locum posts rather than being in training. So it's keeping trainees as well. So we have a really big problem with people getting to like ST3 or 4 and then burning out of surgery and then going and retraining. So that has an impact on how the NHS functions, because once that person comes out of ST3 and goes back down to wherever, that person can never be replaced. We've always lost that level all the way up and through. So we can keep people in employment, I think, by being a bit more compassionate and, you know, letting people have a bit more of control over how much they want to work.
Yeah. Coming back to you now, after we've put the world to rights and solved, you know, staffing problems, is there a particular area of surgery that you are keen to get into?
So I'd like to do pediatric surgery.
Okay.
Mega competitive, and obviously I can't move. So there's one job each year in the country. Now I would always say, you know, the most competitive thing you'll ever do is get into medical school. That's when the odds are highest. But yeah, it feels quite daunting right now.
Is that something that you can kind of work towards, try, you know, circle back, get more experience and work towards? How does that application process work?
So it means quite a niche speciality in terms of getting experience. People don't tend to have foundation jobs in pediatric surgery, and I haven't had one either. In terms of how the application for ST3 works, it's very similar to core surgical training. So collecting, little things like research papers and time spent in pediatric intensive care, neonatal NICU effectively, and meeting some competencies and going from there.
Okay.
Quite involved.
Yeah. Okay. And so you'll be applying for that in next year, the year after?
I don't think I'll be ready. So I should be applying. So the rest of my cohort will apply this time next year. I've got a friend who also wants to do pediatric surgery, and he's full-time, and he will apply next year. And I'm so hoping that he gets a job because he's amazing.
Okay.
I'm less than full-time, so I'm at 70%. So I've got an additional 30% of time to do. I mean, it's actually competency-based rather than length of. I'm, gonna have to do a bit extra. And actually, I'd like to have another baby. So I've to take the account 3. So I really am going for this like family life surgical thing. So I don't think that I will be realistically applying for a couple of years, but I need that time. Yeah, because I'm very stressed right now about the amount of like things that I need to do. So I would love to I might apply next year and see if I can defer. But yeah, very stressful.
Yeah. And I suppose with medicine, there's always another goal to be working towards, but also just about enjoying the job that is happening, now.
I'm so happy. I love it. And I'm so glad that I did it. And my application last year was also really stressful, and it took me a year of being very stressed and, working a lot. But I'm so glad that I did it, and I love it. And, I'm just really happy with it.
Yeah.
I recommend it to anyone. Don't discount surgery. Surgery is really badly taught in medical school. And the reason for that is because you don't get to spend very much time with your consultants or your firms. So you get thrust into theatre with someone you don't know, and it's all very like high impact. Everyone's staring at you. You don't want to put a foot wrong because someone will come and shout at you. And actually, that's not a good learning environment, and it just makes you feel like you're in the way. And no one ever comes to you and says, "Hey, look, do this. It's super awesome." And then the few students that get that experience, they're like, "Oh, I love surgery," but most of us don't get that experience. So yeah, don't write it off. Try and find a good person and go and do some surgery.
Okay. Would you say that's your top tip going through the process of med school?
I think my top tip is just look after yourself. I think the biggest issue we have in med school is that you get I'm going to coin a phrase, which is I can't even think it's like cohort bias, isn't it? It's like because you're competing constantly with all of these really amazing people, and they become your baseline, and you forget that you are all functioning at such a high degree. And we forget that if we do badly on a test, or if we don't know the clinical signs as well as the person next to us, or if we feel like we need to take a year out, or we're just not doing quite as well, then we feel like we're just completely crapping out of life. And it's not true, because every module completed, every day completed at med school, you're doing something that most people can't do. It's so hard. And just well done to everyone who gets through every single day. And if you need to take a year out, if you need to repeat a year, no one's going to care in 25 years when you're a consultant or a GP. No patient who comes and thanks you is going to be like, "Well, I thought you were a really great doctor, but I hear that you had to repeat third year back in 2025. It's just be kind to yourself and don't take it quite so seriously."
And I think as well, just in your general journey, if there's something you really want to try or really do,
do it. Life's short to do something you didn't want to do, and do it on your terms as well. So that's the thing, is that I wanted to do surgery, but I've got 2 children. I'm not willing to not see them. It's not that I want to be a surgeon and a mum. I want to be a mum who's here. I don't want to look up and my daughter be 12 and not want to spend any time with me. I want to be here. I want to catch every moment of that. But I also want to do well at this. And you can do it on your own terms. And I would say to anyone, if you want to go into a really a specialty that's got lots and lots of hours or requires a lot of extra work, because that's the thing with surgery, it's not just the hours, it's all the extracurricular stuff that you have to do. Do it and just drop your hours, like do it less than full time if you can. Do what you want to do.
No, I think that
we've worked too hard to go into a speciality that you don't want to do.
I think also having that confidence to be competitive and be ambitious, but also be able to say, well, no, family life is important to me. I think sometimes people feel they have to choose one or the other, and perhaps valuing family over career can be seen as potentially a weakness in the work environment, but actually saying, no, these two things are both important to me. I can do both, and I can be ambitious and successful and be there. I think that's an awesome message to be putting out there, and just showing people that you don't have to hide one side, or you don't have to devalue parts of life to follow competitive career paths.
Absolutely.
So thank you for that. It's sometimes, I suppose, can feel more isolating in certain environments, and it's having people speak up about it and just show it helps a lot of people. And so on that note, we'll finish up tonight. Thank you so much for your time.
Thank you for having me.
No worries. I will put your Instagram and your YouTube links below so people can find you there, continue on your surgery journey. And thank you so much for your time.
Yeah, thank you for having me.
Thank you.